Dear Pure Urology viewers, good evening one and all. Sorry for 5 minutes delay due to technical issues. Today we are discussing about a specific surgical technique, that is pediatric ureteric reimplantation. The speaker is Dr. N. Mallikarjuna Reddy sir, who is a well-known pediatric urologist from Hyderabad, the place where I also practice. I will introduce sir and then I will hand over the program to Dr. Mallikarjuna Reddy sir. So the topic is pediatric ureteric reimplantation tips and tricks by Dr. N. Mallikarjuna Reddy. Dr. Mallikarjuna Reddy sir is senior consultant urologist, robotic surgeon, pediatric urologist primarily, and minimally invasive urology. Fellow European Board of Urology and Citizen Hospital, Hyderabad, India. Governing Council member, Dr. YSR University of Health Sciences, Vijayawada, Andhra Pradesh. Past President, Association of Southern Urologists, 2021-22. Invited to moderate session on ureteric reimplantation in Turkish Pediatric Urology Centenary Celebrations and SPUS. Invited speaker to Cincinnati Children's Hospital in USA 2016. Faculty to live operative workshops on minimal invasive surgery. Formerly Professor and HOD Department of Urology, Narayana Medical College. Faculty and examiner for Postdoctoral Fellowship of Pediatric Urology, KLE University, Belgaum. He had 51 publications till date and 5 book chapters, and editor-in-chief Journal of Association of Southern Urologists. Invited to be editor of Pediatric Urology section, USA Textbook of Urology. National mentor for robotic surgery and robotic pediatric urology surgery of India. Wrote the chapter on pediatric laparoscopic pyeloplasty in children in UCNA, which is a very famous book, Urological Clinics of North America, February 2015. Dr. Mallikarjuna Reddy, sir, I know for last 20 years as he is practicing in Hyderabad, and also importantly, he has taken an innovative step of doing prostate artery embolization recently, feeling that certain fields, if they are in your area, then try to learn and practice them if they are feasible. Because he feels that angioembolization for any prostatic enlargement or in indicated cases is possible with urologist also by practicing establishing the access to the angio and manipulating the guide wire into the interiliac artery and then doing arteriogram and then embolization is technically feasible for the urologist, and also the urologist can do that. This is one of the unique feature of Dr. Mallikarjuna Reddy sir. He also has given cover you policy, insurance policy while he was the president, which is again followed by majority of the Indian urologists also after his decision. So taking his interest in pediatric urology, we requested today to talk about the pediatric ureteric reimplantation. Thank you, sir, for accepting the invitation. Over to you for the talk.
Thank you, Chandramohan. And it is always a pleasure to be back into Pure Urology. And it's a privilege to be in Pure Urology. Good evening, all of you. Good evening, friends. And then I again thank once more Chandramohan for his very kind introduction. I will actually show you 3 videos. One, I would look at showing you obstructive megaureter. How do we go about? One, tailoring and a reimplant in a case of reflux, and one bilateral reflux. So what are the areas, crux areas, which we should be avoiding so that we don't have complications in future? So I'll just describe you one of the cases. This is a 2-year-old male child with pain abdomen on the left side for 2 months, and he was found to have a solitary kidney with moderate hydronephrosis. The RGP showed obstructive megaureter, and then we went ahead and did a ureteric reimplantation. So what I would show you is now, this is a laparoscopic. I would show a few of the robotic ones. Go very carefully and then start dissecting all around the ureter. the trick here is do not really handle the ureter too much. Now, once you go near the bladder, there are two things. One is you will see I'll just stop the video for a second here. And then what happens is what you will see here is a very specific vessel which comes from the superior vesical artery, which goes behind and then enters posteriorly to the ureter. Once this happens, and if you're not careful here, there will be a very nagging bleed, and this vessel actually goes way down into the bladder, and then it's very difficult to coagulate that vessel. So we would lose a good amount of planes at that point of time. So once you tend to take care of that vessel and then go ahead, then the other thing is this is the vas which will come in. In case of a girl, you would probably have to take care of the uterine vessels. Now you can see that the vas is dissected, and this is the narrow segment, and this is the bladder, and this is the ureter. At this point, because the whole issue is with the tips and tricks, the most important thing, the moment you cut here, this is going to go in and then just get into the bladder, and then you play hide and seek. It becomes extremely difficult for you to actually get this narrowed segment out. So it's always worthwhile that you take a suture before you cut. So in laparoscopy, make sure that your anatomy is with you. So dissect a little more on the vas so that it doesn't come in the way. Your reimplant can always be above the vas also. So when you do that, and if you're sure about it, you can cut. But if not, then you should be able to take a suture. For us, we are sure about what we are doing. And sometimes I do cut because I have the access now. My dissection is perfect. So once this is done, this is another way of doing the tailoring, because this was a big one. We can bring it out through a 10 millimeter port. You see that this is the main vessel, and these are the arborizations. So you can do a tailoring and then put the ureter back into the abdomen and then start reimplanting. Now here comes where we tend to reimplant this back at the same place, so that tomorrow when there is an issue, in case the child develops, grows big and then develops a stone or something, you will see that that particular ureter is looking as good as the normal ureter or the uretrovesical junction. So we do an orthotopic reimplant. So once you have this segment set here, you tend to pick up the bladder so that you will be able to do a good tunnel. You would be wondering why you are seeing this. Sometimes we always measure the tunnel sometimes, and that's a stent which is there. Now you can see that the bladder is opened up. Now you tend to do the tunnel here. The important thing again is we have been taught that when you do the tunnel, you do it with a full bladder. That is one issue where the results of the reimplant would not be very good if you do it in a very full bladder. We should be doing in a half full bladder, because whenever we look at whenever we look at the MCU, if you have a reflux during the filling phase and the mid filling phase, you are pretty sure that that reflux is a low pressure reflux and it's not going to resolve over a period of time. And these particular children will always need a reimplantation. So once you have this narrowed segment and you have the thread on it, you are pretty sure that you can go all around it. Now, this is the way you handle it. You need to go all around. Without the thread, it becomes very difficult because your instruments will clash down there, and it would not allow you. If you are a left-handed person, it's fine that you can exchange your instruments. I do exchange, I do on the left hand sometimes, but as I'm continuing, I didn't want to really exchange the instruments. So the moment you go all around here, you will tend to get into the uretrovesical junction. And these elements of detrusor have to go. If you have these elements of detrusor around, and that would actually again hit the ureter back, pull it back, and then cause reflux. So you need to make sure that there should be no detrusor fibers on the mucosa. Then still, now you see that you see the ureterovesical junction right way down inside. We can actually go cut across like this because there are reports of extravesical Cohen which has been done. So you can actually go across and then do an extravesical Cohen. But I am not a fan of Cohen because if you have to instrument that ureter over in a later stage, you should be able to do it. So you take the suture first through the mucosal opening in the bladder and then cut the obstructed segment. Otherwise, again, there is a problem. Then you will not be able to go in, you keep on holding the mucosa, and then you will end up tearing the mucosa. So once you go in and then do the mucosa, you do that nice end-to-end anastomosis. Now you see this sitting right there. This is pulled out a little. The moment you start doing the dextroscopy, you see that, you can see that the first stitch will always take the ureter behind the adventitia of the ureter. What that does is you take it a little, about half a centimeter above the anastomosis, and this will take it inside and then give you that extra length of intravesical ureter, which will be of help to mitigate the possibility of a residual reflux. Now, once you see that, once you tie, it will just go in. You see that it's going in. And one more suture around that. So 1 to 2 to 3 sutures we tend to advise you all to take onto the adventitia of the ureter. And once you do that, that's fine. The second thing is, there have been a lot of videos which will show you that you can actually pull up the ureter and put it across. We are a few people who would probably not advocate that for one reason, that when you do that, you actually pull the ureterovesical junction out. So once you pull the ureterovesical junction out, then there is a problem that your intramural ureter would get shortened by about a centimeter or so. So we're not happy about that. Now, this is what I'm showing at the end. This is a stent removal. This is a uretero UV junction. This is 1 month down the line. This is opposite orifice. And this is the orifice, and you can see how much length of intramural.
Hello. Hello. Yes, sir. Unmute, sir.
I'm sorry, I don't
No
know.
problem, no problem.
I think there is a issue on a lot of things for us. So
The screen is shared.
yeah.
Yeah.
So I'll now show you a robotic transplant in a girl child. Now, this is a bilateral reimplant. Make sure that you keep the bladder empty. And then generally we use the Maryland and the scissors. I per se would not use an extra port. Very rarely I use the fourth port. Otherwise, I finish off within the 3 ports. And then I use one of these ports to give in the needles and I use sutures to retract the either if needed the uterus and the fallopian tubes. So make sure that you have the ureter, and then as far as possible dissect it carefully. And we know that we will have the uterine artery somewhere here. So so once we dissect this ureter right down till that area, uh, why should we do this dissection is that this will give, now you can see that there is that anterior broad ligament, layer of the broad ligament is now cut. And once we do this, you will be able to just handle the ureter and see where the ureter is. So this will allow us to bring up the ureter into the fold and then do a dead surgery. This was a 4-year-old girl with bilateral grade 4 VUR. We are not keen on sacrificing the uterine arteries here, because in case you have to sacrifice, by chance you sacrifice both, we will end up in a situation of ischemia to the uterus. You can go across, make sure that you are on the ureter and then you pull the ureter. We don't really handle the uterine vessels, because if we injure, then there will be significant bleed. So you keep handling the ureter proximally and then pull it so that you will be able to access the ureter and then dissect exactly on the ureter. Probably people would say you should have had another port and then you can pull it up. But as a pediatric urologist, we were doing all these cases with 3mm ports, getting into a robotic with 8mm ports. We are a little more conservative on the ports. But I am not saying that you should be dogmatically not putting in an extra port. If you are in a difficulty or if you think that you need an extra port, please always put it, because a port never kills anyone. Rather than if you do an open surgery because you are not able to do it, that's going to be far more morbid than doing a extra port. So a fourth port is not an issue at all at any given point of time. And now when you tend to dissect that, you see that now that's the uretrovesical junction there. You carefully do it, and these are the uterines. The moment you have the uretrovesical junction, just sweep in a little of the detrusor there. What that does is it will give you all the area on the mucosa and give you a perfect area for you to come in and then do the detrusor tunnel here. Again, the crux here is to do the tunnel in a half full bladder or 1/3 full bladder. So do one side, then come to the other side. The most important thing, don't go across. We all are pretty sure that there's been significant documented evidence that bilateral extravesical reimplants can cause bladder dysfunction or voiding dysfunction. But then we have realized that when you, the most of the blood, neural bundles of the bladder go medial to the ureter. So if you're hugging the ureter, very rarely you tend to cut the neural bundles to the bladder. The second thing is you need to keep the tissue between these two ureters intact. That's where the bundles would be. And this would, and you will avoid voiding dysfunction. So when you see at the end, there will be a strip of the peritoneum there, which would not be disturbed at all. So this part, you see this here, we would not do anything. And then we're fairly close to the ureter, just close to the adventitia. And again, go up and then do the proper dissection there. So once you go ahead, you see that we are always down there. A little ooze, sometimes it's possible that there's, again, the problem is if you have a fourth port, you probably can suck around. And then we knew what we were doing. So sometimes I don't do it. So I just wantonly kept this video, because a little ooze, you will be able to really still work around with that ooze. So don't worry about it. Once you have everything in your hand, you can comfortably do it. So go ahead, do the detrusor. If you fill the bladder, this actually will fall on you, and you will not be able to easily do the detrusor tunnel. So if you want a suction, you can use a flexible suction like this, which is just a throat suction. You can bring it through the port. That will not leak as long as the cannula seals are okay. And then you can just modulate it. Still keep your port exactly there so that your instrument need not be visualized and it will come right there with its memory. So this is how you can actually suck if you want. But make sure when you start cutting, you do the dextroscopy, then you take this needle. These are 20 silk. Sometimes I take a 20 nylon. Proline becomes a little costlier. So as long as we are Indians, we would look at a little cost cutting. Lift this bladder up with one suture this side and one suture onto the opposite side. And this will allow you to actually open up that area. Don't pull it from outside. If you start pulling it from outside, it will tear the bladder. So always keep pulling from inside and then do it. Now you can see that this area is open, where you can need to do the dextroscopy. Your ureter is here. Then you can nicely cut across. We exchange to the scissors, and then you nicely cut across. Do it both sides. Again, the important thing is do not leave any amount of detrusor tissue on the mucosa. If you leave the detrusor tissue on the mucosa, then you are going to have the detrusor coming in between the mucosa and the ureter, and then very high chance that these ureters will reflux because there is not that kind of buttress and compression between the mucosa and the detrusor. So the finest of the tissues on the ureter should be actually taken off, which is extremely important. And again, whatever I do, I would take a little more extra effort, put a little extra effort, and then make sure that we wouldn't pull the ureter up. So I don't pull the ureter up and keep it. And these are all measured by the ureteric catheter so that we are sure of how much length we should be doing. And we do 1:5. Now, again, that's a big debate in pediatric urology, whether you should do 1:5 or 1:4, whether it is correct or wrong. So a lot of things. So you see that now that it's nicely sitting in this trough. The another important thing we need to see is the moment we finish the suturing, we should not see the ureter. The detrusor should nicely be covering the ureter. If you see the ureter, please place 1 or 2 stitches. Otherwise, this ureter is 100% going to reflux. It's extremely important that the ureter is covered with the detrusor. And if your sutures are loose, do not hesitate to place an additional sutures behind the ureter. So what this does is actually these stitches take the ureter inside and then it nicely fills in. Now you can see that it's nicely sitting into the trough. Go up and then make sure that you don't actually make it so tight as if that there is no space between the ureter and the detrusor. There should be some space. It is one of the arm prong of this should go in so that it is not really obstructive. So once you finish this, at the end you will see that we do the opposite side, but you are able to appreciate this part of it, that this segment should never be traversed and transgressed. And this is the one which will avoid voiding dysfunction in bilateral extravesical transplants. So this is another case where I'll show you. So this is a large ureter. This needs tailoring. So in case when you need tailoring, the important thing you need to do there is do not disconnect that ureter. This is a refluxing ureter. So you can always do a tailoring and a dextroscopy. If you're sure that you cannot do it, you want to disconnect, you can disconnect and do an orthotopic reimplant back again at the exact place, or you can go on the dome. But then a pure pediatric urologist, we would like to make sure that this goes right at that place. But then if you want to do the tailoring, you don't need to disconnect. Do a good dissection at the ureterovesical junction. Go right down there at the UVJ. The vas is here. It's perfect. Once you have that, and then you can again go ahead and then put in the dextroscopy there. I'll share you in another video, which should give you a comfortable Are you able to see anything now? Are you able to see the video? No.
No, sir. No, sir. No.
Okay, I'll do that once. Wait. This is fine now. I think we should be able to see now.
Yes. Yes. Yes.
So now I'll show you how to tailor this ureter. These are large ureters. So once you are careful about the whole thing, now you don't disconnect it. Because always in laparoscopy or robotics, a free structure is very difficult to handle. Now we are pretty sure that this area is quite okay. We have measured this to be 1 centimeter. So I know that I'm cutting half a centimeter. So 5 millimeter ureter would be a 15 French ureter. And once I suture, it would become about 10 French. And then if it heals, it becomes about 6 to 8 French. So that should be a perfect ureter for us to go ahead. The advantage is, because it's a robotic, I'm coming from below upwards. If it had been laparoscopy, I would probably make a small nick here and then come from above downwards, because you won't have this articulating scissors. Place the stent. Now, this is the time you actually place the stent right into the ureter and also into the bladder. Now you can see the width of the ureter. Here you'll always be able to make out the arborization of the vessels, and that is the main vessel which is coming from one of the sides. Let us be clear that though we know that the lower ureter, the vascularity comes probably from the medial side, the lateral side, it's nothing specific, but there is always a long straight vessel which runs across the ureter and then arborizes across the adventitia. So we need to make sure that that particular vessel is always safeguarded. And then as far as possible, do not use too much of energy. If there is something, you can just do a pinpoint coagulation and then use a 5-0 micrel. I tend to do a continuous suturing. I don't have a problem in doing a continuous suturing. And once you suture across, close the ureter there. Do it till the iliac crossing, because we need a little length of ureter to be narrowed down so that the walls go up and then push the bolus back into the bladder. And once you're done that, you can actually comfortably go ahead and do the dextroscopy. I always take these sutures and then hitch the bladder up, which will open up the bladder plane, and then this will give you a great area for you to work around. So once you have the first suture in, the ureter should go in. The moment ureter goes in, you are pretty sure that it's fine. So, and then you finish the dead sonography, you see that. The moment we take the suture, the ureter should intercept or go into the bladder. That will tell you that your reimplant is good, your dissection is good, and this is going to give you a good result. You can be happy. You don't, the follow-up would be only with ultrasounds. Even by chance, people may say, "Oh, do you have a reflux?" Fair enough, I don't know. Even if you have a grade 1, grade 2 reflux, it doesn't matter. But non-dilating reflux is anyway not going to be treated, and these are not bladders which are neurogenic or which are dysfunctional. So these particular children, if the ultrasound says there is no hydronephrosis on full bladder, then post-operatively 3 months to 6 months, we just follow it up every 6 monthly ultrasound until unless someone develops UTI or there is a de novo hydronephrosis, or if the prior hydronephrosis is increasing in size. So the follow-ups almost always are ultrasound. If they develop UTIs, then come the DMSAs and the MCUs into play. Otherwise, it's ultrasounds only. Chandramohan, once again, thank you very much for the opportunity. And it's been wonderful always to be in Pure at any point of time. And it's great. Thank you very much for this opportunity and your kind uh, introduction to. Thank you.
Thank you, sir. Sir, quick questions, few questions.
Yes, please.
Sir, normally, some people will disconnect the ureter and do modified Lesch-Krieger on the anterior surface of the bladder. Whereas
Yes.
in our all videos, you are showing natural course of the ureter on the posterior lateral surface of the bladder. So you are not disturbing the ureteric orifice as such in 2 videos.
Yes.
So in fact, you have not disconnected in refluxing bladder. You tapered up to the lower end and then you pull it up and make the tunnel like in detrosography, classical detrosography.
Yes.
What are the advantages, sir? I mean, it's a normal position actually. It looks like a normal position. Endoscopic intervention is one thing which definitely has advantage in this procedure. Apart from that, any other disadvantage if you drop the bladder and put on the anterior surface in a proper tunnel?
So we were always initially also doing that, Chandramohan.
Sure.
But the point here is we need to look at the bladder. The trigone is the one which is a fixed part of the bladder.
Okay.
And all our ureters are into the trigone. For the simple reason that when the bladder gets filled and emptied, that's where the trigone keeps the ureter stable and then compresses the ureter when the bladder is full, and even pulls it towards the bladder neck when the child is voiding. Now, this is what we are doing. We are now trying to put the ureter back into the trigone so that the ureter stays stable. Once you are on the dome, fair enough that previously we were looking at you have a good tunnel also, but the ureter is a mobile segment on a dome. So we are pretty not sure about what happens when you are actually on the dome. Here, the moment you know that you are actually intercepting the ureter, getting it into, and then you have a great 1:4, 1:5 length of the tunnel, which you measure with the ureteric catheter. I think that is the one thing which we have now stopped doing MCUs for the last few years. And I only do ultrasounds, and my kidneys are perfectly fine with these particular kits.
Okay. So you avoid disconnecting the ureter in that means?
I do avoid if it is a reflux.
Reflux.
But if it is an obstructive, then again you go back and then reimplant there. It takes a little skill to do that. And more so in a girl child would be a little more difficult because of the uterines which would be coming. But I think we have done enough of these even in children and adults. But these are the ones where we have seen that these children don't come back with any issues.
Okay.
On a dome, I have had issues even with intestinal obstruction because once a loop of bowel actually went across the ureter, around the ureter.
Okay. Okay. When it is done anteriorly?
Yeah, it's anteriorly.
Because there will be some space on the lateral.
Yeah.
And what about the intravesicoscopic coherence? A lot of pediatric surgeons do that, though it's a area where both will do. Any comment on Cohen's ureteric reimplantation, vesicoscopic?
Vesicoscopic is not a cup of tea for everyone. I have
Yeah.
also done vesicoscopic, but I feel that the amount of trauma which we do to the bladder in vesicoscopic is far more than what we do from outside.
Okay.
That's number one. Number two, worldwide, the results of vesicoscopic are so poor that they're about 20% lesser than what is done when we do a dextroscopy. If someone is doing an open cohen, that would probably given a good result. But again, open cohen is an intravesical procedure. And for India, which is endemic for calculus disease, we always look at having a option tomorrow to instrument that particular ureter. When we look at the literature,
Following
there's no
Cohen's is very
specific thing.
difficult, sir.
Huh?
Following Cohen's, it's very difficult to intervene because I
No
have
way.
never come
Following
across.
proper coherence, you're supposed to actually puncture the ureter, dilate the ureter like a PCN, and then access the ureter from there.
I mean,
Or if you
antigrade
have, or antigrade, you'll have to do a ultrasound guided kidney puncture and then come in.
Oh,
So even when we do a vesicoscopic, it looks very, what do you say? People may say we don't go through the abdomen and all that. You have to put in three big ports into the bladder. You have to hitch the bladder up. And you cannot do it for children less than 4 years.
okay.
The bladder capacity has to be adequate. And our instrument, it's a robotic, fair enough to you will be, but other laparoscopic instruments, you will tend to cut the mucosa. And if you don't get a proper tunnel across, because both have to go across, then the results are poor.
Sir, sometimes in a mega ureter, you taper and reimplant just like that without cutting. If the ureter is grade 2, grade 3, or recurrent UTI, if it is manageable in a tunnel, do you think that you can avoid in a grade 3 ureter, I mean, not mega ureter, it's this dilated ureter, you can tunnel it back without tapering?
Anything less than 1 centimeter, I think we don't really need to taper it off.
Okay, 1 centimeter is
A
the...
centimeter is what it is. So please measure it inside. Let's not the visual thing. It's best to have the ureteric catheter in, cut it to about 4 or 5 centimeters, and then put it inside. You can wonderfully measure the ureter inside. Or we can have these now. We get these flexible scales also. We can actually measure with But less than a centimeter, you can very comfortably put it into the tunnel.
Sir, what is the stents in pediatric patients you use? Generally 3.5 French size length. When I feel 16 centimeter, it also looks very lengthy for the small child in RIRS because I do a little more RIRS.
Correct. I know.
Even in pyeloplasty, either you have
Correct.
to coil in the bladder or you have to coil more in the
It's okay, Chandramohan. We can always measure you know how to measure, and all of us know how to measure a stent, but we are a little extra careful. We take a 2 centimeter more than what we
more
think we
than what.
measure.
But
But
have you
same,
ever 12 centimeter also? It's available.
it's available. We'll have to ask for it specifically. But I tend to use a 14 because sometimes what happens, you would have seen that post pyeloplasty, these children grow very fast. So we should not have that kind of thing. That's number one. Number two, my dextroscopies are not stented.
Oh,
As long as I don't tailor or I don't disconnect, they are not stented.
oh,
They get a 5 milligram shot of Lasix at the end of procedure, and the ureter should empty into the bladder without getting overtly distended.
okay.
And that is, I'm happy with that.
That's nice. Sir, I mean, theory question, urine culture in dextroscopy and all these things, you ensure that it is completely sterile. Most of the times it is possible. Sometimes if it is not, if it is resistant, we give antibiotics 2 days and go ahead. Is it okay? Or you have to prove
I
sterility?
would almost ensure to be sterile, but in
Sterile.
practice, sometimes it may be difficult. But if there is an ongoing infection, I would definitely not do.
Yeah.
No. I would wait for about 2 weeks of full-fledged antibiotics. Then on suppressive antibiotic, I would do it for the simple reason that post-acute pyelonephritis, these kidneys, post-dextroscopy because of the edema, there is obstruction to these kidneys, albeit it is not total. So if you have an infection along with it, it's going to be exacerbated. So any acute pyelonephritis, I am waiting for 2 weeks with full course of antibiotics, if needed, injectables. Then do a culture, go on suppressive antibiotic, wait for 1 more week, and then proceed with the reimplant, but not before that.
Sir, less than 2 years children in males after any bladder or ureteric reimplantation surgery, how many days you keep Foley's drainage? Do you use oxybutynin? And after how many days you, whether you do Foley's catheterization or infant feeding tube for the drainage of the male babies?
I use a Foley. I have no issues using a Foley. Very rarely I use oxybutynin or tolterodine. Now you have sulfenacin syrups coming up. So very rarely I use that. My Foley stays for about 72 hours in dead storage. But where we have done a tailoring or a total disconnection and reimplant, it would stay for a week. This is India. People who take it out in 24 hours. But last time when I was in Bulgaria, all the catheters they had removed in 48 hours. All those ones who had tapering also, and they were doing very fine. So I think 48 to 72 hours, I'm pretty fine to get them off, because
But discharge also you do in within 1 day.
which one?
Recently, we had discussion that pyeloplasty open surgery, they discharge on post-op day 1, before day 1. Is it?
No, and I didn't want to get into that discussion, General Mohan, so I didn't really jet
I
in.
mean,
But I'll tell you one thing.
generally in your, I'm not
My
asking.
protocol is
3 days we'll keep generally.
either 48 or 72 hours, depending on how the pelvis and ureter is. Look, India, I do not agree with those people that in 24 hours I'll discharge at 48 hours. In India, our admissions are really not an issue, unlike in the West.
Very
That's
rarely
number
people
one.
ask to discharge so that they have to go to work.
They
So
will
as
go
you
to
said,
work. They will go to work. You tell me how many kids you have seen. The father will go to the work, mother will stay, or grandmother will stay.
yeah. Unless
Give also
mother and father are working. I mean, there is no urgency in discharge in India, as a matter of fact.
That's number one. Number two, you pull out in 24 hours, you end up having some leak or some collection.
Fever or something, then
Then
again.
it's become difficult, because that point of time, that is much more worse than having a catheter for a day or two and then drain the pelvis nicely, so that even if there is a small clot, it just tends to lyse and come out. I am pretty sure that my pyeloplasties go home at 72 hours, not before that.
Even I feel so, but it's okay. Anyway, individual experience, no
Yeah.
problem. What is your take on the drains in these procedures? Generally, majority of the child surgeons, they say that drain is a unnecessary pain and try to avoid. Majority of the gynecologists also don't put drain during the hysterectomies and all. But generally, I put a little drain for 1 or 2 days, 40 ml, 20 ml, 30 ml, it will come. After that, we'll remove it. But I also have not seen major leaks more than 1 liter. But sometimes I'm afraid and keep the drain. Always, all small procedures, I keep the drain. You routinely keep drain in ureteric reimplantations and.
I used to drain my pyeloplasties.
Ah,
I used to drain my reimplants. I used to drain my dead surface. I've stopped draining them for the last 5 years.
yeah.
Because when I look back and I saw that, but I would drain a pyeloplasty if it's a huge pelvis, where I had to do a lot of suturing. Number one, yeah, I would drain that pyeloplasty. If the pelvis and the urine is infected and it is edematous, I would drain the pyeloplasty. If it is a pre-stented one, I would drain the reimplant if I do it on the dome. I would drain the reimplant if I tailor it.
Very good. Thank you, sir. Nice. Last question, sir. You are doing laparoscopy for like 20 years and you are recently doing robotic surgery, even 21 days baby you have done pyeloplasty. All these surgeries I am asking pertaining to pyeloplasty, ureteric reimplantation, detrosophy, modified Reddy disconnected ureteric reimplantation, all these cases, I'm feeling that initial part robotic is very difficult. once you come to the suturing part, robotic has advantage. Like initially, bowel will come and you have a focused vision, and ports have to keep kept far away. Ergonomics are totally different. But once you are dissected off, you feel good. What is your frank opinion that if you are good in laparoscopy, no need of robotics, or if you learn robotics, better to the patient can afford? I mean, does it make difference?
Chandramohan, to be frank, I'll tell you, uh, we were it was about a pre-COVID era.
Sir,
We were having a discussion with Asim Shukla, Pramod,
yes,
Craig Peters, and all. I was thrown away from the group and I had to be at the corner because everyone was talking only robotic surgery.
yeah.
Okay. The moment I started doing robotic surgery in 21 and then I put it across to them, every one of them sent back saying that you won't need a robot, man, you will do a good laparoscopic surgery. My results have been the same, both robotic and laparoscopic. Then you are a laggard if you don't do robotics. So I always offer my patients both lap and robotic. I allow them to choose.
Only those who doesn't have money or cannot afford,
They will get
good
laparoscopy.
results can be given with laparoscopy is the
Oh, yes.
message.
Because I don't take more time both on lap or robotics. Okay, I am comfortable in terms of that today you become lazy. You also would know you become a little more
Yeah,
lazier
yeah, yeah.
when you get into
No doubt
robotics.
about
That
it,
is
no
a
doubt.
different scenario. And that's
The
the
entire
only
mindset is like calm, relaxed, sitting, and then
doing it. You are not scrubbed.
yeah,
Someone else is doing
yes,
certain things.
and in fact, assistant role is more in robo than laparoscopy.
Correct. So the reason to do robotics is you can't be a laggard. The world is going on with the robot, and the robots will take over. Whatever may be the make of
Do
the
you
robot.
think that 5 ports, 3 ports are there in the robotics, sir?
IMM are there, but not with Da Vinci yet.
Is it?
Yes, 5mm are there with CMR. They are there with the Revo, and it seems they are coming up with the Chinese robot. The Chinese robot exactly looks like Da Vinci, it seems. I have not seen that. The Bulgarians told me.
We,
So
we don't know.
5mm will come, even the Da Vinci would come up with 5mm with the same kind of wrist. If they have that
By
long
this
wrist,
time, they might have come for pediatric. Anyway, pediatric is evolving now. Uh, mm, anyway, thank you, sir. Thank you very much for the nice discussion. You are experienced and it is reflecting in your talk. Thank you very much, sir.
it's a pleasure always and a privilege to be with you, Chandramohan.
Thank you,
Thank
sir.
you again for the invitation.